Well, good afternoon, everyone, and welcome to the 6th annual Victor and Ruth Dzau Distinguished Global Health Lecture. We are so delighted, first of all, to welcome you all here, but also because this is the first one since the pandemic that we've been able to have in person. So it's really wonderful to be together again and to see everybody here. For those of you who don't know me, I'm Chris Byrer. I'm the relatively newly appointed director of the Duke Global Health Institute. This is my 6th month. So for the OBGYNs out there, it's my 2nd trimester, thinking about it in those terms. And it really has been absolutely marvelous being here, getting to know the wonderful people who make up the Duke Global Health Institute and its wonderful mission of advancing global health equity. I want to first begin by just welcoming all the faculty who are here and the staff and the folks who've really helped make this event possible, particularly Michael Penn and his team, who always do a wonderful job. I also want to acknowledge one of the reasons why we're here in this absolutely beautiful building, the Carr Center, is because we really wanted to reach out to the Triangle area alumni of Duke. So for the alumni who are here, really a warm welcome. I've met a few of you in the reception, but we're really delighted to have you, and that's a part of why this is something of an experiment to do the Dzau lecture here, but it seems like it worked, so we're delighted about that. There are just a few other things I want to say, but we have to begin by acknowledging Victor and Ruth, because this distinguished lecture series really begins with them. We so appreciate your ongoing support for it. It also, we should acknowledge that last year we had a virtual event. It was around this time last year. And for those of you who attended or remember, the two speakers were the late Paul Farmer and Agnes Bingawaho, who was then the minister, or just stepping down from Minister of Health of Rwanda. Of course, this is the 1-year anniversary of Paul's passing is this month. We acknowledge and remember his incredible contributions to this community, and in particular to the Global Health Institute, because his vision, his view of global health equity really is baked into our DNA, and it really helped us, helped all of us. We're acknowledging that, but we're also saying how amazing it is to all be together and to welcome to Duke and to our community a woman who is both a really distinguished leader in global health, and I'm also happy to say a long-time personal friend and colleague of mine, the really extraordinary Dr. Glenda Gray. So Glenda Gray is a kind of hero, and you're going to learn that if you don't know her already as you hear this. She is the first woman to be the president of the South African Council of Medical Research. Now that's the equivalent of our National Institutes of Health. And so that is a very central role in leading the research enterprise in South Africa. And of course, for those of us who know and work on the continent, the research enterprise in South Africa is really unmatched. It's the largest and most important on the continent, and it has played incredibly important roles over decades, but more recently, most recently, of course, in the HIV effort, which Glenda has been a leader in, and then also, of course, in COVID-19. So you're about to hear from somebody who has been briefing Tony Fauci every Sunday for 2 years on COVID and COVID vaccines. So I first met Glenda many years ago. She's a pediatrician, originally, of course, from South Africa. She had started with another colleague at what was then the largest hospital in the world, Chris Hani Baragwanath Hospital in the township of Soweto, outside of Johannesburg, something called the Perinatal HIV Research Unit. which was working at the time. Many of you will remember that the government at the time in South Africa was an AIDS denialist regime that was saying that HIV was not the cause of AIDS, and they were actually actively going after physicians for doing things like providing AZT to pregnant women to prevent transmission. And Glenda and her small team, I'll never forget this office stacked with papers, crowded, crying babies, were taking that on, were doing incredible work that was both clinically meaningful, preventing pregnant moms from transmitting to their fetuses and newborns, but also really laying the foundation for what became one of the just definitive research entities for HIV in the region. And at the time, the HIV Vaccine Trial Network, which I was working for, had not a single site in sub-Saharan Africa. All the sites were funded in other countries, and almost all of them were in the United States. So the NIH made the decision that this simply wasn't going to work and that we were going to have to find HIV vaccine trial sites. So I was tasked with going around the continent, visiting people, trying to find investigators who were interested, populations where we thought trials could happen. And I met Glenda Gray, and she was so dynamic and so exciting and doing such important work and taking on these tough political challenges. And I always remember it because I called the head of the network the next day and I said, I found the first person. And you're going to love her. And he still thanks me. It's 20 years later. I still get thank yous. So Glenda went on to a very distinguished career for that work, taking on the struggle around perinatal transmission. She received the Nelson Mandela Prize in Health and Human Rights from the hand of Nelson Mandela, which is really an extraordinary thing. She is a member of the National Academy of Medicine of the United States, formerly the IOM, which of course, yes, we have to applaud that because, of course, Victor, as many of you may know, Victor Dzau, who's with us, is of course the president of our National Academy. But Glenda is a member. She's also a member of the South African Academy of Sciences and the African Academy of Sciences. So I won't take any more time except to say that Glenda is a person of the highest integrity, the highest commitment, and she's a fantastic scientist, in addition to being a glamorous woman. Glenda, please.
I see the South African flags on there, so thank you very much. And I must say the National Academy of Medicine has definitely got their pound of flesh from me. I was on the board of global health, and I was part of a lot of consensus studies, and during COVID I was also called to give some insight around pandemic preparedness. So you've got your pound of flesh from me, so it's been a great honor. Thank you very much. So I'm going to spend a few minutes just framing the lecture. So if my slides don't move, don't think that I don't know where I am. But first of all, I wanted to thank Duke University and especially Chris for inviting me to give this year's Victor and Ruth Dzau's lecture at Duke. We know that Dr. Dzau is a leader in health and health policy who has committed his life to strive for equity in human health. And it's a great honor to give this lecture. He did mention, as I was starting, that Tony Fauci had given this lecture, and then you told me Paul Farmer had given this lecture. So, oh my gosh, I really have a lot of, great. I'm following the footsteps of great people. So I want to start off by saying that there have been significant medical advances that have been the cornerstone of human development in the last 100 years. We've seen the eradication of smallpox, the defeat of typhoid, syphilis, and some forms of cancer. The availability of drugs, access to water and waste disposal systems, and mass immunizations have managed to control and, in some cases, prevent major lethal infectious diseases. Possibly inspired by this, in 1978, the member states of the WHO committed themselves at alma mater to the primary healthcare strategy of health for all by the year 2000. Hardly 3 years after this relative optimism, there were already warnings of a new deadly in sexually transmitted disease, comparable in magnitude to the worst and the most tragic pandemics in human history. By the time of the Alma Ata date of Health for All, that is the year 2000, the HIV epidemic had already claimed 3 million lives, while a further 36 million were already infected. To date, over 84 million people have been infected worldwide, and 40 million people have died. In the beginning of 2020, the world faced another pandemic, and over the past 3 years, we have seen countries devastated and witnessed the immense human toll from COVID-19. We have lost our colleagues, our friends, and family, with estimates of more than 15 million excess deaths occurring in the last 3 years. At a global level, we have seen the tension between mitigation strategies, public health responses, and human rights. In South Africa, the unfolding of the HIV epidemic and our experience with COVID-19 demonstrates unequivocally the interplay between inherited and long-standing inequalities that play out during these catastrophes. Again, we see how society and its advocates face and respond to these crises. In South Africa, during early democracy, our HIV statistics were a cause for great concern. By 1999, with one in 9 of our citizens being infected, our country was fast becoming the country with the largest number of people living with HIV in the world. Very rapidly, almost 1 in 4 pregnant women were identified as being HIV positive at our antenatal clinics. Even worse, the fact that HIV was the viral agent behind AIDS should no longer have been a matter of scientific dispute. However, AIDS researchers like myself find ourselves in conflict with our politicians, our President Thabo Mbeki, and our Health Minister, Dr. Mantu Shabalala, who were propagating AIDS denialism. Because of the stigma attached to the disease, the initial response to AIDS was a denial of its existence, followed by a need to find a scapegoat for its origin. In South Africa, in the era of President Thabo Mbeki, AIDS denialism became a highly charged political issue. Mbeki created a storm by telling the South African Parliament that a virus cannot cause a syndrome, and argued that the impact in Africa had been exaggerated, stating it was a new name for old diseases like malnutrition, endemic diseases, and unsanitary water supplies. These conditions were not unique to South Africa, but had always been characteristic of the health conditions of the poor. Africa, which accounts for the majority of the world's poorest countries, rapidly was identified as the epicenter of the HIV epidemic. In South Africa, this dalliance, in tandem to racial inequalities of the past, made our country the highest per capita HIV prevalence and infection rate in the world, and cost us over 300,000 lives. The irony is best explained by a desperate remark made by colleagues that work with us, Ellen Whiteside and Cliff Sunter, who said that fate had dealt South Africa a cruel blow by replacing apartheid with HIV as public enemy number 1. So when I started working in HIV as a young pediatrician, we held a conference in KwaZulu-Natal on the 13th International AIDS Conference, and we got a young boy, Nkosi Johnson, who was 11 at that stage, to come and talk. And at the opening ceremony, he asked, and we called the government to make AZT available for pregnant women. A dispassionate Mbeki used his opening address on the same podium at the conference to stress the role of poverty in explaining the problems that faced Africa, and hardly used the word AIDS. He also said in an interview that he did not think that HIV alone caused AIDS, and he set up a presidential panel to investigate the origin of AIDS and HIV. So what we see in South Africa is that life expectancy is inextricably linked not only to disease, but also to politics, economy, and human rights. Apartheid long-standing problems of colonization and inertia regarding transformation in our country has created a fertile ground for pandemics to unearth the cracks in our society. And we will see this both with HIV and with COVID. And here you see life expectancy in South Africa between 1960 to 2015. And you can see that in various phases of our country, life expectancy improved. And one was the link between economic growth and life expectancy. And then during the 80s, we had a time of violence where life expectancy remained static. And then as we move towards democracy, we start to see life expectancy improve. But then HIV starts to emerge in South Africa, and you start to see the reversal of gains that we made. So why did colonization and apartheid build a fertile ground for HIV in South Africa? So the implementation of apartheid and the racial partition of the country resulted in the creation of conditions that made people susceptible to HIV and made preventive efforts much more difficult to mount. HIV, like many infectious diseases of the past, has tended to disproportionately decimate poor communities. Apartheid has, through the creation of Bantustans, or homelands as we call them, and many other instruments of social control, such as migrant labor and segregated townships that still exist in our country, provided the framework within which the epidemic was fueled. So if you go and look at some of the colonization and apartheid structural foundations for racial disparities, you can see that with apartheid, it was racist. It was a racist system of subjugation, political exclusion, and material deprivation. And racist policies in South Africa existed long before apartheid and started with the Land Act of 1913 and the Population and Registration Act of 1950, as well as the past laws that prohibited the movement of black people to work in cities. We also saw separate and unequal education and the barring of black people from certain occupations. And then with the Group Areas Act of 1950, we saw the creation of Bantustans or homelands where people were forced to live and move into the cities for labor and work. So we saw that the apartheid era created this labor system that was circular or oscillating, and migration has been one of the major factors that has contributed to our HIV epidemic. We also saw discrimination in medical training and limited health access. And these limited educational and occupational opportunities exacerbated poverty and led to an increase in transactional sex, age-disparate partnerships, and an unequal power in relationships, which has fueled the HIV epidemic as we know today. So how did HIV move into South Africa? And we saw two routes. The one route was through the apartheid's migrant labor system, where people from all over Southern Africa would move into our mines, and this was noted by John Kuboza, who died soon after this article that he wrote in City Press, where he said that the AIDS bomb is ticking in our minds. At that stage, the health minister announced that they had tested over 2,000 Malawian mine workers in a state-supported compulsory and non-confidential testing program. And all these mine workers were repatriated and were declared prohibited persons. The other route was through contaminated blood products from the US, where we were still buying untested factor VIII and blood concentrates. And this system of buying these contaminated blood products did bypass our South African blood transfusion service. And by the time this was identified, around 87% of the country's haemophiliacs became HIV positive. And when the South African blood transfusion service in 1988 tried to tell the government that there was a big problem with HIV in the country and that they'd already seen 15,000 cases and it was increasing by 50% every month, he was ridiculed at the state's advisory council. So you can already see that these two routes had already entered into South Africa in the mid to late 80s. So we saw the apartheid South African government actively and passively creating a public health disaster, almost a genocide of a mission. And this was a lot of factors, and most of all it is a failure to reverse the inequities in health that we saw, a failure to inform black hemophiliacs and their partners and families about contaminated blood products, the absence of confidential testing in black areas of our country, and suppressing information of the true AIDS problem in our country, and then also by rationing condoms for people who were accessing family planning and other clinics, other health interventions at clinics. So what we see is with what apartheid created was a geospatial locale, and which was related to HIV risk. We see in South Africa extreme racial disparities in HIV infection, which has been a result of structural and historical factors, and that the racial policies facilitating segregation, they still persist to this day in South Africa. And we see in South Africa, if you live in a segregated municipality, your risk of HIV is almost twofold, just demonstrating the geospatial issues in South Africa. So this slide is very instructive about the differences in our populations in South Africa and how historical and structural factors drive disease. In South Africa, we have four main racial groups. We have Black Africans, coloured community, which are largely from Malaysia and come from Asian mixed and white origin. We have Asians that we traditionally call Indians in our country, and white people. And you can see the difference in HIV prevalence by racial group, as well as other factors like education, marriage rate, and sexual debut that paints the picture of the structural factors that drive the HIV disease in our country. So tragically, what we were faced with through the neglect, as we saw, the apartheid government neglected the HIV problem. In early democracy, there were a lot of other things to do, so HIV was neglected. And later, spurred on by aberrant views of Thabo Mbeki, we see life expectancy plummet in South Africa. And when this data first became available, the South African government did not believe the data, and this came from the Medical Research Council, and said that the president of the Medical Research Council at that stage was Malekapura Makgoba, also a member of the National Academy of Medicine, and he was accused of lying, that the data wasn't correct, and he in fact lost his job and wasn't able to complete a second term because of his standing out about the true cause of deaths in young people in South Africa at the time. So what we see in South Africa in the last, since 1990, is you see a steep increase in the HIV prevalence in pregnant women that peaks around 2004 and remains static over the last 10 years or so. So today, as we speak, around 30% of women who come to antenatal care will test positive, and in certain parts of the provinces, like KwaZulu-Natal, up to 60% of young women between the ages of 18 and 24 will be HIV infected. So what was the role of civil society in the new democracy? And civil society found itself at odds with the new ANC government, because they were the very people that had been active and part of the UDF and part of the anti-apartheid movement. So suddenly they found themselves in a very precarious position with the ANC-led government. And what happened was that civil society mobilized around treatment access. We had issues with denialism, issues with lack of drug access, and issues with trying to make sure pregnant women got interventions for their babies. So to look at the global view of how disparities arise. So disparities arise not only because of issues in your country, but also what happens at a global level. In 1997, South Africa was very progressive and passed the Medicines and Related Substance Act, which allowed our country to acquire less expensive generic versions of the drugs. Big Pharma, of course, opposed this, claiming that countries that produce generics committed a form of patent piracy. And even the Clinton Foundation and former President Al Gore tried to put pressure on South Africa to change this law in 1999. Eventually, in 2001, at the World Trade Assembly, there was a declaration on the TRIPS agreement and public health, which allowed countries like Brazil and South Africa to access cheaper drugs, which was the thing that revolutionized access to treatment in our country. We also had an issue where, despite the fact that there were affordable interventions to prevent mother-to-child transmission, we also had a country that refused to give antiretrovirals to pregnant women for their babies. And so this resulted in the Treatment Action Campaign taking the Minister of Health to court, to the Constitutional Court. Fortunately, the Treatment Action Campaign won, and babies were able to receive, babies and moms were able to receive at that stage nevirapine, which later went on to other treatment. But this was an important court hearing, because it was the first time that civil society had taken the new democratic department to court, and thank goodness they had won the court case. So what we see at the beginning of 2000, we start to see treatment becoming available in South Africa, and here you see how deaths in young people increased over time, and then as antiretrovirals became available, you see a decline in death rate, and this is all because of antiretroviral rollout. So antiretroviral rollout starts around 2002 and goes to scale between 2002 and 2006, and you can see the role of that antiretroviral played in improving survival and decreasing death rates in South Africa. And so what we estimate is that the rollout of free antiretroviral therapy reduced mortality by almost 30%, and it decreased the likelihood of reporting poor health by 36% for Black Africans who were young, between the ages of 25 and 49. And so by making ART available, you can see from the estimates and the graphs on your right, is that if we hadn't rolled out antiretrovirals, you can see the rates of deaths we would have seen in females and males. And the bottom chart shows the life years saved by antiretroviral therapy and the reduction in deaths. So quite profound, such a simple thing to give the millions of people in South Africa free treatment, and to see this kind of change in life expectancy was truly phenomenal at the stage. South Africa paid the largest price for not having access to antiretrovirals in a timely manner, and it impacted very negatively on our demographic dividend. Today we have almost 8 million people, or just over 8 million people infected with HIV, and around 5 million of these on treatment. And so still a huge amount of people on treatment and a huge burden of HIV in our country. And yeah, you can see still that even with new cases of HIV, we still remain the epicenter of HIV in our country. So let's move to COVID. I've showed you how racial inequalities, how apartheid, and how an inertia to transform your country, including the geospatial issues that we face. And let's see what happens when we get to COVID-19 in South Africa. And like all of you at a global level, it was like the tale of two cities. There was despair and there was hope, there was tragedy, and there was ecstasy, particularly when particularly when COVID vaccines emerged and we could start to roll them out at a global level. In South Africa, we had this debate, as you have at a global level, looking at the balancing act. So we had to balance a public health with a socioeconomic balancing act, and there was a debate in our country about preventing the loss of life and the issues of the mitigation strategies which would prevent the loss of livelihoods. And there was this balancing act, and there was a lot of social cohesion at the time, and the country decided that the lockdown approach was good because this would help us control the HIV epidemic. So South Africa went into one of the hardest lockdowns in the world. This was very early. When we went into lockdown was on the 27th of March. At that stage, there were just over 1,000 people, from 1,000 people noted to be COVID positive. There were 55 people in hospital, 4 in ICU, and 3 on ventilators. And at this stage, we went into this hard lockdown. There were specific features of our hard lockdown. There was a prohibition of tobacco. We banned alcohol. There was a formation of this National Command Council. Our early childhood development centres were closed, and the school feeding schemes were suspended. So a really tragic hard lockdown which prevented children getting food and prevented them going to early childhood development centres. So there were a lot of pros and cons, and we discussed these. The pros were, if you're going to hard lockdown, you're going to flatten the curve. It brings you time to manage to learn about the disease, to improve the health system response, to help with hospital beds and improve testing. The alcohol ban and the curfew did decrease unnatural deaths and trauma-related hospital admissions. We saw the wearing of masks that became mandatory right early on in public. There was a lot of NPI implementation, and as I said before, there was initial social cohesion and huge public buy-in. And these were used. This lockdown strategy was used as a strategy to contain the waves and surges that we saw on that side. The cons of the lockdown was there was economic devastation with job losses, recession, and poverty. There were tender corruptions around PPE. 40% of our school year was lost, and this impacted the poorest households. As I mentioned before, there was a suspension of the school feeding schemes, which exacerbated childhood hunger. Mental health issues and gender-based violence ballooned. Healthcare delivery was impacted. TB diagnostics declined. HIV care, access to treatment, antenatal care, and immunization of children were severely impacted. And the workplace culture also, as you have here, was completely under threat. What we saw with this pandemic was, again, the exacerbation of inequalities and human rights. And again, we saw that the trade-off between public health and the economy led to deeply racialized, gendered, and class-based consequences in our country. This was our waves, and this is the original introduction came from Europe. And then we had the Beta variant, and then the Delta, and then the Omicron, the first Omicron, and then the second Omicron, and then and then subsequently you can see we have these grumbling outbreaks that we see from time to time. The case fatality rate in South Africa was incredibly high, and so we had a very high case fatality rate, higher than we saw in the United Kingdom or the United States. And here you can see the excess mortality. We estimate about 330,000 lives were lost due to COVID during this time, even though the government reports around 100,000. So we estimate there were 3 times as many deaths as were reported from the cases that were diagnosed. When we looked at mortality risk in South Africa due to COVID-19, we again see the geospatial and the racial issues that we saw in HIV. And if you look at which province you live in, so Western Cape is where Cape Town is. It's the most affluent province. So if you compare our province in Western Cape to rural provinces like the Eastern Cape or Limpopo, you can see that living in a rural province increased your risk of dying in South Africa. You can also see poor people. If you were in the public sector, you had 1.5 more times chances of dying than if you had access to private healthcare. So being in a rural province or being poor increased your risk of dying from COVID in South Africa. Like the rest of the world, we did see an increase in mortality with the older you got, but you can even see that 40 to 59-year-olds, there was an 8 times risk of dying as compared to people under 20. Males were more likely to die than females, but if you look at the race classification, you can see as compared to white people in our country, if you were a black, African, colored, or of Indian descent, you were more likely to die, again exacerbating and showing the racial disparities and inequalities in our country. So what about the impact of COVID-19 on lives in South Africa? What we saw that when you look at the impact of the mitigation strategies, we saw deepening hunger and food insecurity, a loss of income and livelihoods. We saw decreased access to education, increased violence at the hands of security forces, and lots of illness and death. Here's just some pictures of how militarized the country had become. Army was sent into townships. People died if they weren't at home. And you can see the police brutality that we saw in our townships across the country. We also saw a lot of xenophobia, and during the time of COVID, life became quite unbearable for migrants in South Africa at times where people were asked to produce your ID so you could buy food in the country. What about women and COVID? We saw a gendered impact of COVID. This shows you, these slides show you the employment to population ratios and compares employment over time, and you can see that women were more likely to lose their jobs as compared to men, and it took a long time to recover, and even now after March 2021, women still hadn't recovered the employment rates as compared to men. There was about 3 million job losses, and of those, majority of women lost their jobs. But there was even more gender-based response. So South Africa made a distress grant available. Now, this distress grant was 350 Rand, which is, I think, the equivalent of $25, if that. And when this was announced, 3 million people in our country queued to get this social relief of $25. But you can see, if you look if you compare men getting these grants as compared to women, you can see that in terms of successful applications, only 36% of women were able to get their applications, and that women already were discriminated when it came to accessing these social relief packages. We saw, like at a global level, a decrease in school attendance as compared to other years, and as I mentioned before, a 40% loss in the school year. When you look at urban versus rural, people running out of money, you can see a lot of people ran out of money to buy food in all parts of the country, but people in rural provinces were more likely to run out of food as compared to people living in cities or towns or in metros. So again, poor people in rural provinces were hard hit by the lockdown. People ran out of money to buy food, there was household hunger, and there was child hunger that was exacerbated over time. We saw a lot of demonstrations in our country trying to get people to get their jobs back, and also a lot of looting and corruption from the money that was made available for PPE and things like that. We also saw at the time a desire for vaccination. So at this stage, this was late 2020. There was COVAX. There was a mad scramble to do bilateral agreements with pharmaceutical companies and to try and make sure that we could get vaccines into our country. At this moment in time, you can see around just between 40 and 50% of South Africans have been fully vaccinated, and a variability according to provinces. And so around 40 to 50% of South Africans have been vaccinated, and mostly with the 26 or the Pfizer vaccine. At the time of the beta variant, South Africa had procured AstraZeneca vaccine, and we had no data that the vaccine would work against the beta variant. We had some preliminary data from South Africa that showed huge viral escape from neutralization, and the country panicked because there was no vaccine. Fortunately, I had been involved in a vaccine study with J&J, and we were able to influence this relationship and convince J&J to give us 500,000 doses of the vaccine for our healthcare workers. And this was truly a labor of love. It was a donation between J&J and the US government. J&J collected all its investigational vaccines from all over the world, flew them all into Belgium, and we were able to bring this vaccine into South Africa. What was very beautiful about this is that we were able to demonstrate very early on that by vaccinating healthcare workers, we were able to decrease hospital admissions and COVID-related deaths, and we were able to demonstrate that this vaccine worked both in the Beta and the Delta and the Omicron variants of concern. We were able to show, both with the Pfizer and the A26 vaccine during the Omicron periods, that our vaccines were effective, and we could reassure the public and the healthcare workers that the vaccines were working. But we did see, like at a global level, a lot of vaccine hesitancy, and so we only had between 40 and 50% of South Africans eventually being vaccinated, and started to look at vaccine hesitancy. People were concerned about the side effects. There was a lack of access to our electronic vaccine data system that affected vaccination rates. A huge distrust of the government that fueled vaccine hesitancy. A belief in conspiracy theories, not having a monthly income, or depending on someone else to make your decisions impacted access to vaccines. So looking back at the hard lockdown and looking back how our pandemic, how the COVID pandemic worked in South Africa, the question we ask in South Africa is, did the trade-off work? Did we justify, did this draconian lockdown justify the health outcomes? And what we did see was that the state of disaster and the restrictions had become an excuse for police misconduct, but also political misconduct. And so did this trade-off work, and did this mitigation of hard lockdown actually save lives in South Africa? In fact, probably what saved lives in South Africa was the emergence of hybrid immunity. And so during each of our waves, we saw a very close correlation between cases, hospitalizations, and death. And when the Omicron wave emerged, when we looked at how much neutralization escape happened, we were absolutely terrified that we were going to have death and devastation in our country. And what we saw was an uncoupling of our cases from hospitalizations and deaths. And this was because of the hybrid immunity that we saw in South Africa. By this stage, during the Omicron period, around over 90% of South Africans had been exposed to SARS-CoV-2, and that, together with with moderate levels of vaccination, actually protected the population with Omicron. And so we were very fortunate to have this hybrid immunity in South Africa that, more than mitigation, probably saved our country. So finally, I've got my last two slides. What are the lessons that we've learned from HIV and COVID-19 in South Africa? So COVID-19 in South Africa already emphasized what we already knew about the inequality and poverty in South Africa, and how this drives health outcomes. And that despite democracy, the failure to address the legacies of the past will continue to plague us when it comes to responding to diseases that place poor people at risk. These racial disparities that I showed you continue to exist in our country, and are particularly exacerbated by the geospatial segregation that we find in South Africa. And this poor health access continues to drive adverse health outcomes. So if we are truly committed to changing the health outcomes of our country, there has to be a much more meaningful movement to true and meaningful transformation that our democracy has failed to achieve since 1993, 1994. So we've been, at the Medical Research Council, we've been looking at the role that science or the Medical Research Council plays in health inequity, and to try and see how us as the Medical Research Council can change this. And so we do recognize it's important for the Medical Research Council to recognize the catastrophic and persisting consequences of colonialism and apartheid, including the land dispossession and the intentional imposition of educational and health inequities among citizens in our country. And we acknowledge the role that the MRC played and was silent on it, and sat back and watched the health and research inequalities occur. And so we now, as the MRC, commit our capacity and resources to make sure that we can promote equity and dignity in health and healthcare in South Africa. So thank you very much.
Well, Glenda, thank you so much. That was extraordinary. And I think particularly for the Americans in the audience, the resonance of the power of these legacies and the way that they continue to impact health inequities. We saw very similar outcomes with COVID, as I'm sure you know, and it's an important lesson. We have some time for questions, if folks would like to ask questions of Dr. Gray. And the way we're doing this, rather than moving around with microphones, is we're going to ask you to be brave and come up and stand here. Victor, please.
Thank you, Dr. Gray, for honoring me and my wife and all of Duke community for being here and present this really very important lecture and lessons learned. You know, as Chris said, I think we share many of your observations in our country. And last week we had Marcella Nunes-Smith talk about her experience, particularly during COVID, in her work about equity, and there's so much similarity. We have a long way to go. As I reflect on what you talked about, there are really two issues I thought that ought to be brought up. One is the importance of the voice of community, right? The CSO, the civil society, plays such an important role in the HIV movement. So I'm wondering where we can now mobilize those voices with regards to not only COVID, but ongoing issues that we're faced with. The second issue is the whole idea of regional independence, if you will, resilience. We learned so much from COVID as we look at global issues together that actually a lot of things were forgotten about the importance of regional strength and regional self-reliance, such as vaccine manufacturing, purchasing, you name it. So we can talk about those two things and what are lessons learned for all of us.
Sure. Civil society is imperative, first of all, to address the health inequalities that we see, but also to drive the agenda forward about a new vision. And if it wasn't for the HIV civil society who mobilized during COVID, because they quickly saw how HIV, we had data that showed that if you were HIV infected, you also doubled your risk of dying. And so there was a mobilization. But also the very same people that were involved in the TRIPS agreement or the Constitutional Court quickly realized the issue around patent protection and the lack of access because of patent protection. So we were fortunate enough to become an mRNA vaccine hub for our region, and we started to develop mRNA vaccine capability. But we very soon we had to figure out, we had to decode the whole structure to make our vaccine, and it wasn't, luckily we had people like Bart Haynes and Bonnie Graham that were on our advisory group who could give us good advice. But we really soon found out that Pfizer and Moderna were not willing to work with us, and we had to weave our way through all the intellectual property issues that we face. And so civil society is very important. So civil society is important at a community level and at a government level to raise the issues of inequality and the issues that face poor people. But they're also important to take on the big structures, things like the World Trade Organization and the situations that poor countries find themselves in because of patent protection. And that big pharma don't support access to treatment. And we see it with long-acting cabotegravir, for instance. The indication was found. If it wasn't for the women in southern Africa, we would not know that it worked. And yet these very same women, the price is out of their reach for access at 400,000 Rand a year, which is out of the reach of the government. And so I think it's important for us to, at many levels, and for society, for community, at many levels, to take on your government, your municipality, but also to put your head up and say, how do world trade agreements affect our ability to get treatment. In terms of expanding manufacturing capability, that's very important. So South Africa and Africa has to become more self-reliant. We can't depend on the global north, for fair, fair trade. And so developing local manufacturing is an imperative. It's a moral imperative. It's an economic imperative. But we have to find a way how we understand global procurement. So there's a lack of transparency when it comes to global procurement. And Africa as a bloc will need to put up some demands. And if we do have local manufacturing, is that we're going to have to make sure that Africa buys 60% of its goods from African companies to keep that incentive going. So we can't just we can't be dormant for years and then only respond when there's a pandemic. We have to get into the production of vaccines and continue to do that, and then move or pivot to a pandemic vaccine if the need arises. But very important that the global South starts to interrogate the way the world screws us over all the time.
Well, your President Ramaphosa is very visible and quite a strong voice in this issue for the global South, and he plays really important roles. And I think the issue of civil society for us in this country, we need to mobilize more of that voice of community to be able to push our government to do more. Thank you.
Thanks.
Anybody feeling? Is that a hand up or just a hand bag? Oh, please. Oh, hey, how are you?
Thank you so much, Dr. Gray. Following on that same set of ideas around civil society and also African self-reliance, how do you see the academic sector kind of playing in? Because having moved from South Africa about a year ago, I see South African academics as working a lot with civil society to push these agendas forward. And I think in some ways that's lacking in the US. I'd just love to hear your insights about how South Africa has mobilized together with academics and civil society.
Yeah. So there's a lot of emphasis in our country about research translation. Mm-hmm. And knowledge is not knowledge just for itself, but that it has to lead to something. And maybe the U.S. universities and departments can start to look at how each academic is involved in knowledge translation, and that becomes an indicator for promotion, for tenure, and for stature. So if so I think that knowledge translation is an important part of knowledge creation, and that we should push or treat or train our scientists to actively translate that knowledge, and not just to leave it at the publication level.
Mm-hmm. Thank you.
So first, thank you so much for your presentation. It was very enlightening to see kind of this transition from a lot of the misinformation surrounding AIDS, the condom rationing, to ultimately offering free ART. So I guess in the wake of seeing increases in kind of behavioral health, mental health issues, an increase in like intimate partner violence, increases in kind of cycles of poverty and unemployment, how is South Africa moving forward to rebuild kind of the trust of the public in the wake of not seeing the public health outcomes that we'd like to among the COVID restrictions?
South Africa needs a renaissance, needs a revolution. We need to address there are lots of issues. We need to address first and foremost the issues of corruption that we find in our country, to free up the money so it can go into things that will change people's lives. So we need the money out of the hands of the corrupt and into the hands of people that can deliver services. We need a service delivery revolution as well. And if we have good service delivery, particularly in poor areas, you can begin to address some of the lack of access to health and issues around health access. We need to deal with the segregated townships that we still have, and find ways of breaking down those geospatial areas. And so there has to be a huge commitment to a radical transformation of the country, and by doing that, I guess then there's a trickle down effect. The more women go to school and complete their schooling, the less teenagers get pregnant. The more people go to university and get an education, the less poverty there is. The less poverty there is, the less vulnerable women are to transactional sex and intimate partner violence, and can become empowered. So without jobs and education, we'll find ourselves in that spiral that continues. But what we do need is a radical transformation of the way we do business in South Africa. And it's going to be interesting what we see in the next elections about how power changes, and whether this power change will be good or bad for South Africa.
Thank you.
Elections have consequences. I think we're close to the end, and I'd like to ask everybody to come back and join us for the last part of the reception. But before we do that, please do join me again in thanking Glenda Gray for this.